Hello and welcome to Medaculus. Today's topic is atrial fibrillation. Atrial fibrillation is a supraventricular tachyarrhythmia resulting from irregular, disorganized electrical activity and ineffective contraction of the atria. AF is associated with electrophysical and/or structural abnormalities of the atria. The autonomic nervous system may also play a role in some cases. The triggers for AF are rapidly firing foci, most commonly within the pulmonary vein. These triggers cause propagating wavelets, which may lead to reentrant circuits in abnormal atrial myocardium. When the atrioventricular node receives more electrical impulses than it can conduct, an irregular ventricular rhythm results. The ventricular rate of untreated AF often averages between 160 to 180 beats per minute, although this is typically slower in older people. Classification. Sustained AF results from structural remodeling of atrial tissue, most notably fibrosis. AF is classified according to the pattern of episodes. Paroxysmal AF, episodes lasting longer than 30 seconds but less than 7 days, often less than 48 hours, that are self-terminating and recurrent. Persistent AF, episodes lasting longer than 7 days. Spontaneous termination of the arrhythmia is unlikely to occur after this time, or less than 7 days but requiring pharmacological or electrical cardioversion. Permanent AF, AF that fails to terminate using cardioversion, AF that is terminated but relapses within 24 hours, or long-standing AF, usually longer than 1 year, in which cardioversion has not been indicated or attempted, sometimes called accepted permanent AF. Causes. Atrial fibrillation is most commonly associated with hypertension, coronary artery disease, and myocardial infarction. Other etiologies include cardiac or valve conditions, such as congestive heart failure, rheumatic valvular disease, atrial or ventricular dilation or hypertrophy, pre-excitation syndromes, such as Wolff-Parkinson-White syndrome, sick sinus syndrome, congenital heart disease, inflammatory or infiltrative disease, such as pericarditis, amyloidosis, or myocarditis. Non-cardiac conditions, such as acute infection, autonomic neuronal dysfunction, such as vagally induced AF, electrolyte depletion, such as hypokalemia and hyponatremia, cancer, such as primary lung cancer involving the pleura and pericardium, and cancers such as breast cancer and malignant melanoma metastasizing to the pericardium, pulmonary embolism, thyrotoxicosis, diabetes mellitus. Dietary and lifestyle factors, such as excessive caffeine intake, alcohol abuse, especially in susceptible individuals such as those with structural heart disease, obesity, smoking, medication exposure, such as thyroxine or bronchodilators. Complications. Stroke and thromboembolism are the main complications of atrial fibrillation. People with AF have a greater risk of stroke and thromboembolism than people without AF. However, this risk is not homogeneous and is dependent on the presence of various stroke risk factors. Stroke severity is usually greater when stroke is associated with AF than with other causes. Peripheral thromboembolism can also occur. Anticoagulation treatment reduces the risk of stroke by about 2/3. Heart failure is commonly associated with AF. Heart failure can occur because the disorganized electrical conduction in the atria results in ineffective ventricular filling. The cardiac output can be reduced by as much as 10 to 20%, pushing an already compromised ventricle into failure. Tachycardia-induced cardiomyopathy and critical cardiac ischemia may result from the persistently elevated ventricular rate seen in uncontrolled AF. The mortality rate of people with AF appears to be correlated with the presence and severity of concomitant cardiovascular disease. AF is also associated with reduced quality of life. AF can result in reduced exercise tolerance and impaired cognitive function. A systematic review of 49 studies found that people with AF have significantly poorer quality of life than healthy controls, the general population, and people with coronary heart disease. The risks from paroxysmal AF are thought to be similar to those from persistent or permanent AF. Diagnosis: suspect atrial fibrillation in people with an irregular pulse, with or without any of the following: breathlessness, palpitations, chest discomfort, syncope or dizziness, reduced exercise tolerance, malaise/listlessness, decrease in mentation, or polyuria. A potential complication of AF, such as stroke, transient ischemic attack, or heart failure. Absence of an irregular pulse makes a diagnosis of AF unlikely, but its presence does not reliably indicate AF. Past medical history that may further raise suspicion of AF includes cardiac disease, including valvular heart disease, coronary artery disease, hypertension, pericarditis, cardiomyopathy, and other arrhythmias, and/or recent cardiothoracic surgery. Non-cardiac conditions including diabetes, thyroid disease, cancer, and alcohol misuse. Suspect paroxysmal AF if symptoms are episodic and last less than 48 hours. Be aware of the differential diagnoses of an irregular pulse. To confirm a diagnosis of AF, arrange a 12-lead electrocardiogram. If AF is present, the ECG will have no P waves, a chaotic baseline, and an irregular ventricular rate. The ventricular rate is often 160 to 180 beats per minute, but can be lower, especially in people who are asymptomatic. The ventricular complexes look normal unless there is a ventricular conduction defect. If paroxysmal AF is suspected and AF is not detected on standard electrocardiography, arrange ambulatory electrocardiography. A 24-hour ambulatory ECG monitor is normally used in people with suspected asymptomatic episodes of paroxysmal AF, incidental finding of an intermittent, irregular pulse, or symptomatic episodes that are less than 24 hours apart. An event recorder ECG is normally used in people who have symptomatic episodes more than 24 hours apart. In some centers, a 7-day Holter monitor is used as an alternative to an event recorder, especially when asymptomatic paroxysms of AF are suspected. Differential diagnosis. The differential diagnoses of an irregular pulse include atrial flutter, characterized by a sawtooth pattern of regular atrial activation on the electrocardiogram. Atrial extrasystoles, common and may cause an irregular pulse. Ventricular ectopic beats. Sinus tachycardia, sinus rhythm with more than 100 beats per minute. Supraventricular tachycardias, including atrial tachycardia, atrioventricular nodal reentry tachycardia, and Wolff-Parkinson-White syndrome. Multifocal atrial tachycardia, often seen in people with severe pulmonary disease. Sinus rhythm with premature atrial or ventricular contractions. AF management. If the onset of atrial fibrillation, AF, was within the last 48 hours, urgently admit to an acute medical unit for emergency electrical cardioversion if the person is exhibiting signs and symptoms of hemodynamic instability, such as a rapid pulse, greater than 150 beats per minute, and/or low blood pressure, systolic blood pressure less than 90 millimeters of mercury, loss of consciousness, severe dizziness or syncope, ongoing chest pain, or increasing breathlessness. If the person is not exhibiting signs of hemodynamic instability, consider management in primary care, if appropriate, or refer the person to an acute medical unit for immediate cardioversion, depending on the person's preferences and clinical judgment. In people with AF presenting acutely with suspected concomitant acute decompensated heart failure, seek senior specialist input on the use of beta blockers and do not use calcium channel blockers. Note: in practice, most people with symptomatic acute onset AF are likely to present and be initially managed in secondary care. For all other people with AF, including paroxysmal AF, admit or refer with urgency dependent on clinical judgment if the person exhibits any of the following: signs and symptoms of hemodynamic instability, signs suggestive of a stroke or another serious associated or underlying condition such as severe heart failure, pulmonary embolism, pneumonia, or thyrotoxicosis. Assess for signs and symptoms and arrange tests to confirm or rule out underlying causes of AF, including Cardiac causes, such as hypertension, valvular heart disease, heart failure, and ischemic heart disease. Review of the electrocardiogram may identify an old myocardial infarction. Arrange a transthoracic echocardiogram if there is a high risk or suspicion of underlying structural heart disease, such as a heart murmur, or functional heart disease, such as heart failure, that will influence subsequent management, for example, choice of antiarrhythmic drug. Respiratory causes, such as chest infection or lung cancer. Arrange a chest X-ray if lung pathology is suspected and use clinical judgment to determine the need for urgent assessment and referral. Systemic causes, such as excessive alcohol intake, hyperthyroidism, electrolyte depletion, infection, or diabetes mellitus. Use clinical judgment to determine the need for thyroid function tests, full blood count, and/or blood urea and electrolytes, calcium, magnesium, and glucose measurements. Refer to a cardiologist. People with a pre-excitation syndrome such as Wolff-Parkinson-White syndrome, valvular heart disease associated with AF, suspected heart failure with or without a previous MI. Refer to an endocrinologist. People with suspected thyroid disease. Refer to a pulmonary oncologist if lung cancer is suspected. Refer to a cardiologist for consideration of pharmacological or electrical rhythm control, cardioversion. People including those whose AF has a reversible cause, for example a chest infection, who have heart failure thought to be primarily caused or worsened by AF. For people being managed in primary care, assess the person's stroke risk using the CHADS-VASC assessment tool. Assess the risk of bleeding using the Orbit Bleeding Risk tool when considering starting anticoagulation in people with AF and when reviewing people already taking anticoagulation. Offer monitoring and support to modify risk factors for bleeding, including uncontrolled hypertension, poor control of INR in people taking a vitamin K antagonist, concurrent medication including antiplatelets, selective serotonin reuptake inhibitors, SSRIs, and nonsteroidal anti-inflammatory drugs, harmful alcohol consumption, reversible causes of anemia. Discuss the results of the assessments of stroke and bleeding risk with the person taking into account their specific characteristics, for example comorbidities, and their individual preferences. When discussing the benefits and risks of anticoagulation and the available drugs, use clinical risk profiles and personal preferences to guide treatment choices. Discuss with the person that, for most people, the benefit of anticoagulation outweighs the bleeding risk. For people with an increased risk of bleeding, the benefit of anticoagulation may not always outweigh the bleeding risk, and careful monitoring of bleeding risk is important. Offer anticoagulation with a direct-acting oral anticoagulant to people with AF and a CHADS-VASC score of 2 or above, and consider a DOAC for men with AF and a CHADS-VASC score of 1, taking into account the risk of bleeding. Apixaban, dabigatran, edoxaban, and rivaroxaban are suitable options. Do not offer stroke prevention therapy with anticoagulation to people aged under 65 years with AF and no risk factors other than their sex, that is, very low risk of stroke equating to a CHADS-VASC score of 0 for men or 1 for women. Do not withhold anticoagulation solely because of a person's age or their risk of falls. If DOACs are contraindicated, not tolerated, or not suitable in people with AF, offer a vitamin K antagonist. For adults with AF who are already taking a vitamin K antagonist and are stable, continue with their current medication and discuss the option of switching treatment at their next routine appointment, taking into account the person's time and therapeutic range. Arrange follow-up to carry out any required monitoring, assess compliance with treatment, and any adverse effects. Offer a rate control treatment, either a standard beta blocker, other than sotalol, or a rate-limiting calcium channel blocker, diltiazem or verapamil, as first-line treatment for most people with AF. Base the choice of drug on the person's symptoms, heart rate, comorbidities, and preferences. For people with AF and concomitant heart failure, follow the NICE guideline on chronic heart failure. Digoxin is a possible alternative in people with non-paroxysmal AF if they do little or no exercise, or if other rate-limiting drug options are ruled out because of comorbidities or the person's preferences. Arrange follow-up within 1 week of starting treatment to review tolerance, symptom control, heart rate, and blood pressure. Do not offer amiodarone for long-term rate control. Consider referral for cardioversion for people whose symptoms continue after heart rate has been controlled or for whom a rate control strategy has not been successful. Refer people to be seen within 4 weeks if treatment at any stage fails to control the symptoms of AF and specialist input is required. Provide information on. Provide written information on the causes, effects, possible complications, and management of AF. Explain when to seek further medical advice, such as if symptoms worsen, stroke awareness, and how to prevent stroke. Written information is available from the Stroke Association. Flying. Advise that there are no flying restrictions provided AF is stable and has not recently worsened or become more symptomatic. Driving. Advise the person that it is their responsibility to inform the driver and vehicle licensing agency, DVLA, of any condition that may affect their ability to drive. For Group 1 entitlement, cars, motorcycles, the DVLA's medical rules regarding AF are that driving must cease if the arrhythmia has caused or is likely to cause incapacity. Driving may be permitted when the underlying cause has been identified and controlled for at least 4 weeks, and that the DVLA need not be notified unless there are distracting or disabling symptoms. For Group 2 entitlement, lorries, buses, the DVLA's medical rules regarding AF are that people are disqualified from driving if the arrhythmia has caused or is likely to cause incapacity, but that driving may be permitted when the arrhythmia is controlled for at least 3 months. The left ventricular ejection fraction is equal to or greater than 0.4. There is no other disqualifying condition. Review any person with an established AF diagnosis at least annually. Follow up a person with atrial fibrillation. Follow up after starting rate control treatment. Within 1 week of starting rate control treatment or any dose alteration, check that the person is tolerating the drug and review symptoms such as palpitations, breathlessness, and fatigue, heart rate, and blood pressure. Criteria for rate control vary with age, and it is suggested that ventricular rate should be controlled between 60 and 80 beats per minute at rest and between 90 and 115 beats per minute during moderate exercise. In clinical practice, the target heart rate during exercise may need to be adjusted depending on the level of exercise the person can manage. For example, a rate of 170 beats per minute is inadequate rate control if the person has only walked up the corridor. If the person cannot tolerate the drug, prescribe an alternative rate control drug. If the person's symptoms, heart rate, and/or blood pressure are not controlled, consider one of the following options. If they are not taking the maximum drug dose, consider increasing the dose to control symptoms. If they are taking the maximum drug dose, consider combination treatment with any 2 of the following drugs: a beta blocker, digoxin, or diltiazem, off-label use. Seek specialist advice before prescribing diltiazem with a beta blocker because bradycardia, atrioventricular block, asystole, or sudden death can occur with concurrent use. If symptoms are not controlled by combination treatment, refer promptly, within 4 weeks, to a cardiologist. Follow up after starting anticoagulant treatment. For people taking warfarin, assess anticoagulation control regularly. Initially, a person started on warfarin should have their INR monitored daily or on alternate days until it is within the therapeutic range, between 2 and 3, on 2 consecutive occasions. Then, monitor twice weekly for 1 to 2 weeks, followed by weekly measurements until at least 2 INR measurements are within the therapeutic range. Thereafter, depending on the stability of the INR, monitor at longer intervals, for example, up to once every 12 weeks, if agreed locally. Calculate the time in therapeutic range, TTR, at each subsequent visit to ensure that the person is maintaining an international normalized ratio, INR, between 2 and 3 over a longer period of time. Calculate TDR over a maintenance period of at least 6 months. Use a validated method of measurement such as the Rosendal method for computer-assisted dosing or proportion of tests in range for manual dosing. Exclude measurements taken during the first 6 weeks of treatment. Poor anticoagulation control is indicated by any of the following: TTR less than 65%, 2 INR values higher than 5 or 1 INR value higher than 8 within the past 6 months, 2 INR values less than 1.5 within the past 6 months. Note: some adults with AF on long-term warfarin can be supported to self-manage with a coagulometer. For people with poor anticoagulation control on warfarin, correct factors contributing to poor control, if possible, such as impaired cognitive function, poor adherence to prescribed treatment, illness, use of concurrent medications that may interact with warfarin, lifestyle factors including diet and alcohol consumption. If poor anticoagulation control cannot be improved, consider switching to a direct oral anticoagulant, DOAC, apixaban, edoxaban, dabigatran, or rivaroxaban. Reviewing a person with AF. Review the person at least annually once symptoms are controlled and any drug treatments/dosages are established, or more frequently if necessary, using clinical judgment to determine appropriate intervals. Check for symptoms of AF at rest and during exercise, and assess the heart rate. Review the person's medications. Check symptomatic control, compliance, and identify and manage drug interactions and adverse effects. For people taking a rate control treatment who have persistent symptoms of AF or a fast heart rate, consider one of the following options. If they are not taking the maximum drug dose, consider increasing the dose to control symptoms. If they are taking the maximum drug dose, consider combination treatment with any two of the following drugs: a beta blocker, digoxin, or diltiazem, off-label use. Seek specialist advice before prescribing diltiazem with a beta blocker because bradycardia, atrioventricular block, asystole, or sudden death can occur with concurrent use. If symptoms are not controlled by combination treatment, refer promptly, within 4 weeks, to a cardiologist. For people who have received a rhythm control treatment who have recurrent or persistent symptoms, refer back to a cardiologist for further assessment. Reassess the person's stroke risk using the CHADS-VS assessment tool and bleeding risk using the Orbit score tool, at least annually. Stroke risk should also be routinely reviewed when a person reaches 65 or years of age, or if at any age they develop diabetes, heart failure, peripheral arterial disease, coronary heart disease, stroke, transient ischemic attack, or systemic thromboembolism. For people not already taking an anticoagulant, offer treatment if they have a CHADS-VS score of 2 or more, and consider offering anticoagulation treatment to men with a CHADS-VS score of 1. For people already taking an anticoagulant, do not stop anticoagulation solely because atrial fibrillation is no longer detectable. Base the decision to stop anticoagulation on a reassessment of stroke and bleeding risk using CHADS-VS and Orbit and a discussion of the person's preferences. Manage any modifiable risk factors for bleeding, such as uncontrolled hypertension, concurrent use of aspirin or a nonsteroidal anti-inflammatory drug, harmful alcohol consumption, and reversible causes of anemia. For people taking warfarin, assess anticoagulation control. For people taking rhythm control drugs that were initiated in secondary care, such as amiodarone or sotalol, if a shared care arrangement is in place, carry out any required monitoring. Assess and manage cardiovascular disease, CVD, risk. Assess for and manage complications of AF, including stroke and thromboembolism, heart failure,